Hi class, we left off on this slide on Thursday when I was addressing some neurotransmitters, hormones, and drugs that can bind to your adrenergic receptors and provoke change. You should definitely know which of these drugs, neurotransmitters, hormones can bind to if they can bind to each of these adrenergic receptors. Notice that dopamine can bind to alpha-1 and beta-1 receptors as well as to dopaminergic receptors. Norepinephrine can only bind to alpha-1, alpha-2, and beta-1. Epinephrine can bind to the adrenergic receptors straight across the board. Isoproterenol can only bind to beta-1 and beta-2. Ephedrine can bind to all 4 adrenergic receptors shown here. Phenylephrine, which is the new formula for Sudafed, only binds to alpha-1. Clonidine binds to alpha-2, and albuterol binds to beta-2. And I'm going to go through these in the next few slides, and then I'll talk about antagonistic drugs to the adrenergic receptors. To remind you, these adrenergic neurotransmitters / hormones are all derived from tyrosine, and this is not the first time we've seen this slide. Tyrosine is converted to L-DOPA, which in turn is converted to dopamine, and then norepinephrine, and then epinephrine. And to remind you, norepinephrine is primarily used as a neurotransmitter, and epinephrine is primarily used as a hormone. Let's talk about the alpha receptors. Alpha-1 receptors, where are they found? They're found on the smooth muscle found within the tunics of the blood vessel, specifically the tunica media. We also find them on sphincters that allow chyme or fecal matter to pass through the gastrointestinal system. We also find them in the kidneys, specifically the renal artery, and we find them on blood vessels, like I said, throughout the body, but not all blood vessels. Alpha-2 receptors, I'm going to hold off on this until I see you in class again. They're found in the presynaptic membrane, and if you're not careful with those terms, you're going to be misled. You're probably confusing right now presynaptic membrane with preganglionic, and that's not true. These receptors are actually found on the postganglionic neuron. But remember, the postganglionic neuron synapses with an involuntary effector, and therefore the postganglionic neuron actually is presynaptic to the involuntary effector. And these alpha-2 receptors are going to be a part of negative feedback inhibition at its best. Basically, when the postganglionic neuron releases epinephrine, this is going to bind to the alpha-2 receptors, and when the alpha-2 receptors are bound by epinephrine, the very epinephrine released by this neuron, these alpha-2 receptors are found on the neuron, it's going to lead to a decrease in further release of epinephrine. So it's self-negative feedback inhibition. Clonidine acts as an agonist on these alpha-2 receptors. So it would inhibit any further release of epinephrine when it binds to alpha-2 receptors. And this is used to treat hypertension, because if the blood vessel is not receiving epinephrine anymore, then the blood vessel will relax and will be vasodilated. Beta-1 receptors, again, the most important place for us right now where we find them is on the heart. And when they are stimulated, it will increase the force of heart contraction, that's called inotropy, and it will also increase heart rate, which is called chronotropy. Beta-2 receptors are found on smooth muscle that lines, in particular, lines the bronchioles, and this would lead to bronchial dilation. However, there are some blood vessels that also have beta-2 receptors on their tunica media, and this would lead to vasodilation. Beta-3 receptors are found on adipocytes, and when they are stimulated, this would increase lipolysis. Now, you've heard me say that blood vessels have alpha-1 receptors, but they also can have beta-2 receptors. If alpha-1 and beta-2 receptors are found on the tunica media of the same blood vessel, it's hard for a student to evaluate what would the blood vessel do. the alpha-1 is stimulated, it's going to lead to vasoconstriction, and beta-2 leads to vasodilation. So which one wins and when? Well, on this screen, you're seeing that there are many more alpha-1 receptors found on the tunica media than beta-2. But the beta-2 receptors have a higher affinity for epinephrine. So if epinephrine is around in low amounts, as shown in the bottom left picture, then preferentially the epinephrine loads and stimulates on the beta-2 receptors, and this leads to vasodilation. However, if and when epinephrine levels are very high, say in a severe fight or flight moment, then it's clear to see that all the beta-2 receptors and alpha-1 receptors, all of them, are bound by epinephrine. In this case, when all are bound, numbers reign. There are more alpha-1 receptors than beta-2, as shown in this bottom right picture, and therefore the blood vessel would vasoconstrict. Dopamine, as you heard me say in class, is a very quirky one. To date, there are 5 known types of dopamine receptors, and they're quirky. We find that dopamine can be inhibitory or excitatory depending on where you are in the brain. And remember, it's not the neurotransmitter that determines if it's inhibitory or excitatory, it's really the receptors. And these dopaminergic receptors are particularly quirky. They can downregulate, they can upregulate, they respond to dopamine in different concentrations. It is just overwhelming. I have a lot of research papers on dopamine, and trust me, it's hard to keep it straight. I do like the picture, however, on the slide towards the right, and this is showing you a dopaminergic neuron. I'll remind you, when we turn these terms into an adjective, dopaminergic, adrenergic, cholinergic, that adjective tells you that it either makes that neurotransmitter or can respond to it. For example, a dopaminergic neuron would be a neuron that makes dopamine. A dopaminergic receptor would be a receptor that binds to dopamine. You get the idea. So in this picture, you're seeing that there is a drug called L-DOPA in the blood that can cross the blood-brain barrier and go into these dopaminergic neurons and used as a precursor to make dopamine. Now, this is a problem with people with Parkinson's disease. They lose their dopaminergic neurons. We can give them some drugs, but the drugs we give them will really mark the beginning of the end. Sadly, we wait until their quality of life has been impaired so much, and then we start them on these drugs. And it really comes down to a fight between acetylcholine and dopamine. And both of these neurotransmitters are important with respect to movement. Acetylcholine, of course, stimulates skeletal muscle, but dopamine will inhibit neurons from firing and stimulating, ultimately, somatic motor neurons that innervate skeletal muscle. So when we give a person dopamine, the problem is it can't cross the blood-brain barrier, but its precursor, L-DOPA, can. As shown here in the top right of this picture, the issue is when L-DOPA is in the bloodstream, when it's taken as a pill, we have enzymes in our blood that can actually degrade L-DOPA. And so now we need to give L-DOPA to this patient, but with other drugs where the enzymes can't get to L-DOPA. So this drug that blocks one of the enzymes is called carbidopa. And again, in the bloodstream, we have an enzyme that destroys catecholamines called COMET. And you saw this on my catecholamine slide. And we can also give a drug to a patient, or a few drugs, that will block the COMET. Remember, COMET and MAOs are the enzymes that destroy catecholamines. So we can also give this person tolcapone and entacapone, which will block the COMET enzyme and make the L-DOPA, carbidopa, last longer. Then when the L-DOPA actually gets into the cell, it can be converted by the neurons, the remaining neurons that are there, into dopamine. The problem is when dopamine is released at the terminal bouton, as shown at the bottom here, there's an enzyme again in the synaptic cleft called monoamine oxidase, or MAO. And again, we can give MAOIs to block the destruction of the dopamine, allowing more time for the dopamine to stimulate any downstream cell. So again, this is our cocktail of drugs that we can give a person with Parkinson's disease. But we wait until their quality of life is so low, and then we start these. Why might we do that, you might be asking? Well, again, L-DOPA has to go into these neurons and be converted. The problem with Parkinson's disease is they're losing these dopaminergic neurons. Eventually, there's no place for the L-DOPA to go to. So we have them use their own neurons for as long as they can until so many of them are depleted that they aren't getting enough dopamine. Then we start them on this cocktail of drugs. Their symptoms improve, but eventually they are losing more and more neurons. Of course, we think of some famous people who have Parkinson's disease, like Michael J. Fox, and I'm sure you can think of others. It's a movement disorder, and like I said, it's a balance between dopamine, which has inhibitory effects for these movement centers in the brain, blocking unwanted movement, and acetylcholine, which stimulates skeletal muscle. I told you about the carbidopa-levodopa combination mix to get L-DOPA across the bloodstream. We can block COMET, an enzyme in the blood. We also can give MAOIs, which will block monoamine oxidase found in the synaptic cleft. To continue on with that chart with a list of drugs, let me tell you about phenylephrine. Phenylephrine stimulates alpha-1 receptors. It's the new formula for Sudafed. Sudafed is taken as a decongestant. In your nasal cavity, in an area right next to your external nares, if you were to put your finger in your nose and then touch the top of your nose just at that entrance area, that's called Kieselbach's area. And there's a lot of blood vessels in that area. And when there's a lot of blood flow and you're making mucus, you get congested. So if you take phenylephrine, or the old formula of Sudafed, pseudoephedrine, it would stimulate the alpha-1 receptors, and this would cause vasoconstriction, which means less blood flow to your nasal cavity, less mucus, and less congestion. The problem with ephedrine is that the pseudoephedrine can be used to make methamphetamines, and now it's definitely highly regulated. I don't think the ephedrine is as good as the pseudoephedrine, and here's why. The pseudoephedrine can be metabolized into norepinephrine, and remember the receptors that norepinephrine can bind to. It's a lot more than the phenylephrine, which only binds to alpha-1. So because of this cross-reactivity with the pseudoephedrine, I found that my nasal congestion was better abated when I took the old formula than just the new one that stimulates alpha-1. The isoproterenol, I remember this as pro for you, like I am so for you, and that helps me remember that it's a sympathomimetic. It's lame, I know, I agree, but it works for me. And it helps me remember that it's going to stimulate beta-1 and beta-2 receptors. This is great if you have asthma, because then with the stimulation of beta-2 receptors, you're going to get bronchial dilation. However, it's contraindicated if a person has high blood pressure, because the beta-1 receptors are also stimulated, and this would lead to a greater force of heart contraction, which leads to a greater blood pressure. Dopamine, as you have already seen, is both a neurotransmitter and a hormone, and can be administered as a drug. It stimulates alpha-1 and beta-1 receptors, and we give this for a person who has hypotension, too little blood pressure. We give this to a person who might overdose on phentolamine, which is a drug I'll discuss next. Albuterol is a drug that stimulates beta-2 receptors, again found on smooth muscle. When albuterol is inhaled, it's going to stimulate beta 2 receptors on bronchial, smooth muscle that lines bronchioles and leads to bronchial dilation. As I have already mentioned, there are some drugs that are metabolized into norepinephrine, like ephedrine, pseudoephedrine, methamphetamines, amphetamines. There's a whole class of them, and they definitely have sympathomimetic effects. These drugs shown here are blockers of adrenergic receptors. To say that again, they're antagonists. These are going to block the effects of norepinephrine. They're alpha blockers, like phentolamine. Well, if you block alpha blockers, then you're not going to get vasoconstriction. Instead, you'll get vasodilation. Phentolamine used to be the cheap man's Viagra. They can take it orally, and because they're blocking the vasoconstriction, the counterpart of that is vasodilation. So their corpora cavernosa would vasodilate. But there was a problem with this drug. Because so many of the blood vessels vasodilated, it wasn't just targeting blood vessels serving the corpora cavernosa, it was systemically. With a drop in blood pressure systemically, the heart has a reflex arc to this, and it actually induced tachycardia. And you will learn in Unit 3 that tachycardia means an elevated heart rate. And when the heart rate elevates, the heart itself is now working harder. And the irony is that it doesn't get as much blood. That's not good. A harder working tissue getting less blood flow is a perfect mix for disaster. More on this to come. Also shown on here is a drug called propranolol. Be careful with this one. It sounds a lot like isoproterenol, doesn't it? Propranolol is a beta 1 and beta 2 blocker. If you are blocking the sympathetic response, then all you have left is parasympathetic. And now you start asking yourself, what would you see in the patient? This propranolol specifically blocks beta 1 and beta 2 receptors. This is great for a person with high blood pressure, maybe from the heart beating with too much vigor, too good of a contraction. This would be good for them, but bad for a person with asthma. With asthma, there's too much bronchial constriction. So if we gave this drug to a person, it would block their beta 2 receptors as well in the lungs. And if you're blocking the ability to bronchodilate, then the only thing you have left is bronchial constriction. So this would actually would make it harder for a person with asthma to breathe. Clearly contraindicated in this reference.